talking about financing healthcare and health insurance. These numbers are from '08, so they're a little bit old. But in '08, these were the areas where more than 80% of expenditures came from. So obviously about 31% was hospital care, 21% was physician and clinical services, 10% was prescription drugs, and 10% was other dental personal care services. About 9% was nursing home and home health care. And the remaining 20%, administrative costs, equipment, public health, things like that. Allison, see me after class, please. All right. How do we pay for it? Well, some people pay out of pocket, or we call it private or self-pay. Then you have private health insurance, that's your Blue Cross, Aetna, United. Other private funds, or public funding like Medicare, Medicaid, state children's health insurance program. And you see that that number is the largest. That's how we pay for our care. So key changes in the evolution of the health insurance industry. Here are a few of them. Well, obviously, comprehensive health services and benefits has increased. The increased role of public and private sectors in healthcare coverage. What that means is more people have started to pay for coverage. Health insurance as an employee benefit, that has grown. We'll be interested to see how that changes though in the next few years. Changes in reimbursement and the continual rise in healthcare. So what's the history behind health insurance legislation, right? Believe it or not, conversation started way back in the 1930s about health insurance. At that time, it was seen as socialized medicine. Then we had Medicare and Medicaid in '65.
Wow.
Yeah.
I thought it'd be longer than that.
No, it's pretty recent. In '97, we had the Children's Health Insurance Program started. And just recently in 2010, had the Patient Protection and Affordable Care Act. It's most recent. So what are a few terms in health insurance that you probably should know? Risk pooling, forms of payment, cost sharing, policy limitations, types of benefits, maximum out-of-pocket expenditure. These are all terms you should be familiar with, and you'll probably become more familiar with them if you take the medical insurance course, which is HMT 210.
And what is that required for?
HMT 210 is a
Is it like an elective if you're doing the national program like that?
yeah, and in your
Kinda
case,
like this.
yeah, if you wanted to, you could. Yeah. There is a few prerequisites though. This one, and I'll talk to you after class starts. So what are some concerns related to health insurance? Choice of provider, right? Everybody wants to be able to go to the doctor they want to. They want to be able to choose it. Access to care. What about people living in rural areas that don't have the best access to care? Restrictions on care. You can't have this procedure done because it's not covered. This happens a lot with, I see it happen a lot with weight loss procedures, like gastric bypass, things like that. Moral hazard, pre-existing conditions, and buy downs. All concerns related to health insurance.
What's a buy down?
Buy down, that involves actual pricing.
Like negotiating?
Right.
Okay.
Yeah. So what are the types of health insurance? We have the conventional, and we have the managed care plans, right? HMOs, PPOs, we've all heard of those, right? So there's different types of HMOs. You have the closed panel HMO, the group model, open panel, staff model, the independent practice association, and the network model HMO. I'm not gonna go into each of these because that will take a while, but if somebody wants to know more about them, we can talk about it.
Which one does the military one fall under?
TRICARE is separate. We'll get there. So this table kind of shows you from 1988 to 2009 what types of health plans people were enrolled in. Is there anything that sticks out to you? Anybody?
Conventional,
The last one.
conventional insurance
Conventional,
declined
Decline.
substantially.
PPOs.
PPOs,
The last one.
the last one, this one. All right, so there's been some changes in enrollment plans. Everything you all said was right. As you can see, PPOs is growing in popularity. HMOs stayed about the same. It kind of went like this. Conventional obviously went down dramatically, like you said. And the last one. So what do you think that those trends kind of tell you, right? A story about the history of health insurance and how things have changed, just based on the differences in enrollment plans, right? This slide talks about the history of social insurance. It lists several different acts that took place. I'm not going to go through all of them, but I think for our sake, right now, the most important one is probably the Patient Protection and Affordable Care Act, because there's going to be a lot of discussion about that in the next few years. Medicare. Does anybody know anybody on Medicare? Everybody? I know somebody. We should all know somebody. There's an eligibility criteria. You have to be elderly, right? Over 65. Or permanently disabled, younger adults. A lot of people think that Medicare is just for elderly people. That's not true. Also for disabled individuals, individuals that have end-stage renal disease. Everybody know what that is? Kind of kidney.
Is she on dialysis?
Yeah, dialysis. Or terminally ill patients. So if you have a terminally ill disease,
And also children on SSI. Don't they qualify?
don't confuse Medicare with Medicaid.
Oh,
We'll get there. Medicare has different parts. There's A, B, C, and D. So A is hospital insurance. What that means is if they go into the hospital, that portion of Medicare is going to deal with that. Part B is supplemental. Kind of covers whatever isn't, kind of picks up the slack for everything else. Part C is Medicare Advantage, and Part D is prescription drug. So here are the sources of Medicare revenues. You have the general revenue, payroll taxes, right? You look at your paycheck, you see Medicare on there, so it's 38%. Payment from states, beneficiary premiums, interest, and taxation of social. So you see these two are the top ones. That's how Medicare is funded. So why is the growth in Medicare spending? Why has it gone up? Well, it's been a shift from acute to chronic care. People are more, they're living longer, so they're sicker, right? Cancer is on the rise, those types of things. There's been a growth of hospital expenditures. Hospital bills are going up, which means Medicare spending is going to go up. Fee-for-service reimbursements, growth in pharmaceutical costs, same thing, costs going up. Advances in medical technology. We talked about this a few weeks ago about, IT and the growth of technology in healthcare. It's going to affect the spending. Increased payments to health plans, as well as rural health providers, and rising medical malpractice premiums. I don't know if you guys realize it, but as physicians have to pay malpractice, that cost gets transferred to everybody else. Unfortunately, that's how they stay in business. Reimbursement efforts to control Medicare spending. Well, they have something called DRGs, and it's very complicated, so I won't get into it that much. But you also have physician office visits, skilled nursing facilities, home health agencies, and hospital outpatient departments services. These are all things that have been put in place to try to control the spending. So, we have concerns, right? We always have concerns, especially when it comes to Medicare, because we all want to be able to have access to it, right? So some of the concerns are continuing expansions of benefits. Are the benefits going to continue to keep up with the costs?
nope. Not
Access,
right.
access to Medicare participating physicians and providers. In some places, there may only be a small number of physicians that want to be a Medicare provider. Why might that be?
Because they only pay a percentage of
Right.
their bill.
It's
Just like
the
TRICARE.
lowest payer, right? So if I'm a doctor, I have my own practice, and I work to feed myself and my family and maintain my lifestyle, if I accept all these Medicare patients, am I making any money? Probably losing money, right? So this one's important.
Are they required to accept a certain percentage or no physicians?
It depends on a lot of things, but there are some that don't. Um,
Yeah, the dentist is the hardest place to get in.
Yeah. So that's a big concern, is being able to, having Medicare is fine and wonderful, but if you have Medicare and you can't go anywhere to get care, how, what is it worth? So access is very important. Continuing increase in program spending and program solvency. People are worried that it's going to go away. They're not going to have enough money or run out of money. There's not going to be any Medicare. Now we're getting into Medicaid. Here are the criteria for Medicaid. It's coverage for the medically indigent. Everybody know what that means? Okay, so AFDC and SSI recipients, I think that's what you were talking about. Coverage for pregnant women, children, and infants. And expanded coverage for children via CHIP. Expanded coverage in some states includes those with higher incomes in relation to the federal poverty level. So what that means is, depending on what state you're in, you may be able to receive Medicaid in one state, but not necessarily receive in another, depending on your income level. Medicaid is jointly funded by federal and state. So here's the breakdown. The federal share is about 50 to 77% of costs, and the state share, again, this depends on the state, so that's why there's a range, but the state share is 23 to 50% of costs. Welfare magnets, programs that offer extensive expanded eligibility as well as many additional benefits. Everybody know what that means?
People that like WIC or
Right.
something else,
Yeah.
another type of program
Right.
funded under
Like health choice here?
Right, yeah, exactly. Guys are sharp. So here's some of the benefits. Services mandated by federal legislation. Inpatient hospital stays, outpatient hospital, physician services, labs, nursing facilities, home health services, EPSDT. Now, here are some services that are added at the state's discretion. Again, this is going to vary from state to state. Like you talked about, dental care, mental health care, drug and alcohol treatment, rehab, preventive care, prescription drugs, and prosthetics. So just like Medicare, we have some concerns with Medicaid, right? Number one, growth in Medicaid spending. Again, the growth in spending is a big concern. Increases in volume and increases in provider payments. Increasing number of beneficiaries. How are we going to be able to provide for all these people, especially now considering, we've gone through this recession, so more people have lost jobs, so the number of recipients has probably grown. How are we going to be able to fund all of these people, right? It's a big concern. Downturn in the economy, unemployment, uninsured population, all reasons why we're concerned. And continued expansion of benefits. Now we're getting to TRICARE. Covers veterans, active and retired military personnel, and their families. You have the DoD medical facilities. Can anybody give me an example?
Oh, man.
There we go. We have one right here. And we have a VA. And we also have CHAMPVA, which is kind of a VA medical program. So what are the criteria? Again, active duty, retired military and families. Includes DoD's 536 hospitals and clinics. And 3 program options are HMO, PPO, and fee for service. So to answer your question, within TRICARE, here are the 3 program options.
I've never seen that. That must be standard crime and.
Let me call it something else. Yep. Benefits. Hospital care, physician services, prescriptions, diagnostic tests, preventive tests, and dental services for active duty. Funding, there's no enrollment fees, and this is subsidized completely by the federal government. Co-pays are required, and some are required to meet annual deductibles. So what concerns might we have about TRICARE? Anybody in here on TRICARE? You are. What concerns do you have?
Well, mine really, I don't have any concerns for myself. I do for other people. We were here before they implemented that you have to take your children on post and things like that.
Yeah.
That's the one thing about TRICARE that I didn't like when I was on it was if you got care somewhere that wasn't under the TRICARE thing and they're supposed to reimburse you and all the stuff that you have to go through just
Yeah.
to get to that point.
Yeah.
That was me.
It's not that bad anymore. You just get a pre-authorization.
Limited network, kind of just talks about that, being able to find people that accept TRICARE. And it's kind of the same scenario with Medicare and Medicaid. Some people don't, TRICARE isn't the best payer either, so.
It's terrible.
Yeah, so there's gonna be some providers that are like, no, I don't want any TRICARE patients. So a limited network could be a concern. Difficult to provide care into National Guard and Reserve personnel. And think about all the people on TRICARE, approximately 9.2 million beneficiaries. It's a lot of people, right? All right, let's talk about Veterans Health Administration. All veterans obviously are eligible. They have VISNs in 22 regions, and the benefits vary depending on enrollment categories. So CHAMPVA coverage is provided to non-retired veterans, those that are permanently and totally disabled, spinal bifidal healthcare program, and the Women Vietnam Veterans Healthcare Program. So what are some coverage statistics generally of health insurance? About 58% are covered by their employer, meaning, whoever you work for provides some type of coverage. About 9% are direct purchase private health insurance people, so these are people that purchase health insurance on their own. Medicare and Medicaid are both about 14%. Military health care is about 4%, and those that are not covered are about 15%. It's approximate numbers. So, here's the cost, approximate. Again, this is 09, so might be a little off. But individual coverage, all plans, $4,800. It's annual. Does that seem high or low?
It's high.
It's like what, $400 a month?
It's high.
Two Texas. Family coverage, about $13,000. Sounds like a lot, right? Even for a family, $13,000 a year.
That is a lot, especially if you don't go to the doctor's office.
Right.
Well,
Yeah,
with
especially if
those-
you're just doing like well checks every
Yeah.
year.
And with
Yeah.
those, you still have to pay all the deductibles.
Copay or whatever, yeah.
Yeah.
So, and again, this is 09.
It's going up
Yeah.
substantially since 09.
Yeah. So, this shows you kind of the distribution of those that are uninsured by age. Does anything stand out to anybody?
It's the 25 to
The
34.
older people.
65 is the number.
The older people? What about it?
They're covered.
Because they fall under
to look
Medicaid.
up.
Right.
Medicare.
Yeah. Anything else?
The younger, the
This,
25 to 34
Right.
is the biggest.
Yeah.
well, that's.
Well, these two.
I'm going to say the 45 to 64.
Well, we can speculate why this one is this.
College,
Yeah.
yeah.
What do you think about this one?
Loss
They're
of job.
retired or lost a
Nearing
job.
retirement and can't qualify for Medicaid. till
Right.
65.
Many.
Right. I just read an article
Medicare.
about, earlier today about people in their 50s having trouble finding jobs because of kind of their age, where they are in their career. And it's been hard for them to get hired.
Walmart,
that's obviously gonna affect this number, right? No job, you're not being covered by health insurance. So I think it's important for us to look at these two, as managers, to realize where our uninsured population may be coming from. Sure, I mean, we have these two categories that are not low necessarily, they're both
And that was
around-
in 2008?
Yeah,
Oh, wow, I'm sure that category 45 to 65
Yeah.
has really gone up.
Yeah, it's
because of
probably
the job
wider.
loss.
yeah,
I mean, because of the economic
yeah.
situation.
What are some characteristics of the uninsured? Well, they say a quarter are from families with income below poverty level. Only a quarter. I think that's important to note. Most from families with incomes above poverty level, but under the 300% level. Most were workers or dependents of workers employed in industries that don't provide health insurance, right? Some of these people are working, their employer has decided not to cover them. What types of employers do you think this?
Mom and pop stores.
Yeah, small ones that can't afford to purchase it. They're not covering them because they don't want to, they just can't afford to do it. More uninsured people in the South and West than in the East and Midwest. And they aren't covered because they can't afford it, not because they don't need it.
I have a question real quick before you go on. Canada, what is it so special about, is it because the cost of living is so high, why you don't have to have insurance?
Everybody contributes to,
We have a socialized
Right.
insurance program.
yeah,
Everybody's covered.
Yeah, I know
Yeah,
it's
but
free.
it's not the
wise, but
greatest
I want,
either.
like, now that we pay through our paychecks and all
Yeah.
that other stuff for these insurance, so what do they do? That's all.
well, I don't know if I would say it's not the greatest, but the wait time is very long.
Yeah, I
Yeah.
have been over there to the doctor before.
Yeah. Like sometimes you have to wait months and months for procedures, whereas here,
Or just to get in for a
Yeah.
well check for your child. I
Yeah,
mean,
you
because
have to be here too.
yeah,
Or you pay in school, don't get taken care of.
we
Yeah.
had moved and didn't want to change TRICARE, and so I just went over the border. We moved to Detroit and took forever.
yeah. Utilization of the healthcare system by uninsured. We're thinking in the mindset of a healthcare manager. We have to service everybody that comes through our doors, right? Regardless of their ability to pay.
Why is that? 'Cause you can't deny medical.
Right.
Because you can have family members too,
Mhm.
and
Yeah.
all that kind of stuff.
Even though they owe a bill,
You mean
like, like say they went,
there's laws that say that
Just get a bill and
at
if
a
you don't pay the bill,
minimum,
just goes
you have to
into
at
it.
least stabilize them. You can't just deny care
Okay.
legally.
That's all they do.
Here's what happens. People without insurance obviously aren't getting well checks, they're not going frequently to the doctor, they're putting off being seen. So what happens is, when they usually show up, it's pretty urgent because they haven't been seen and whatever it is in them has probably been, growing or whatever. And so what happens is, as an organization, it's a big hit every time somebody without insurance comes through the doors, because it's possible that it could have been something that was prevented had they been coming to check us. Let's just take heart problems, heart attack. Had they been getting frequent checkups and being able to maintain that heart issue, it probably will cost the hospital a lot less than them having a heart attack and having to pay a cardiologist or whatever, or use certain supplies or whatever technology to take care of the issue now, right?
You're not getting payment because they're not insured.
Right. And so in the end, the hospital or the physician office or whatever it may be is going to end up losing a whole lot more money. And so what happens is disability, premature death, or preventable health problems, as I just talked about. And it utilized the most expensive access point to healthcare system, which is the emergency department, right?
Because primary care doctors won't accept them, correct? I mean. or
Well,
will,
that,
I mean, if they owe them a bill, they're not gonna see them.
right,
pay for
that,
services rendered.
and their hours are limited. You know what I mean? Like, a lot of people are probably going to the ED because whatever it is happening on the weekends or after hours, or but yeah, that too.
I just wondered if the laws were the same for private.
Not
practice.
exactly. Not
If they
not
have to
exactly the
see
same
someone
for a
that was
hospital
injured.
versus a, yeah.
I have a question. Like, for all this insurance and stuff like that, like, how can they bill, you know, like you go do a visit, basically, how can they bill the child a bill?
Bill a child?
Like, cause they don't know, I guess, the age or whatever, but like my daughter, I got a bill in the mail, and this was from 2 years ago, she had surgery to move fingers and toes. So they sent her a bill and her name and her social for $10,000. But she had Medicare, or which one? Medicaid.
Well, they're gonna, regardless of the patient, they're gonna bill whatever that patient is. And what some hospitals will do is, if they decide to not turn it over to collections or whatever, like sometimes hospitals can place liens on you or your property. So in an example of a child, they might bill them, and if for whatever reason they weren't covered by, you know, Medicaid or whatever, it might be something that's just kept on their file until they become of age.
Wow.
Well,
Yeah.
usually you have to sign as a consenting adult.
Right, yeah.
So even if they build
It's
your
gotta be on
even if
somebody.
they build your child, like, you know, they bill me, but
Right.
my husband is the one responsible to pay
Yeah.
because
So-
he's a TRICARE provider. So it would fall on the parent, right?
Oh, yeah. But they're gonna get the money sometime. Somebody's gonna get billed. Yeah. But you're right, yeah, obviously. Because usually you'll see on the application, it'll say patient or
Uh-huh.
adult or parent or consent.
I mean,
Guardian.
yeah, it's
Yeah,
usually, it's
right.
usually in the fine print, but yeah.
Yeah. Most uninsured obviously don't have a primary care physician, and so that kind of goes back to the whole reason that they show up at the ED. They don't have a doctor's office to go to. So we talked about this a little bit. What are some management implications? Managers become involved in selecting health insurance plans for employees and considering benefit packages, cost of coverage, and other issues.
And I've heard the hospital insurance is some of the worst. Is that true? I don't know. I've never worked for the hospital system, but
It depends. When I worked for a hospital system, the insurance is pretty good.
is it?
It was, but it depends on a lot of things. You know, how big the
Yeah.
hospital is, if it's private or you know, profit, nonprofit. The system that I worked for also had a health insurance company, so I'm sure that helped as well with us having good rates. So it just kind of depends. Somebody else have a question? No. Managers also have to understand healthcare insurance plans and coverage for themselves, so they're able to relay that information to employees as well as patients or customers. They have to have some knowledge of coding and billing and the reimbursement policies and procedures. You don't want to be the person in charge and you don't have any knowledge about the health insurance coverage, right? This, I think, is most important for just being able to service your customers or your patients, right?
There's a question.
Yeah. So I think that while, you know, this course covers a lot of things and we won't talk about health insurance a lot in this course, I think that this chapter is very important because health insurance is about to change, and we need to make sure that we're keeping a pulse on what the changes are, because those patients will be coming into our offices or our hospitals, and we need to make sure that we know how much their reimbursement is and how much their copay is, and understand.
When does that policy go into effect for that act?
I think it's next year.
Yeah, 2014.
Yeah, it said
Everybody has to have it.
2014.
Yeah. That's my understanding. Yeah.
And then will other health insurances go away or just?
No.
I guess I haven't read
Everybody
up
has to
on
have insurance.
enough. It's
Right.
just for people that don't have insurance.
Yeah. Any other questions about what we talked about, or just health insurance in general? I think you had, your question about,
Paying.
about if you have to see them. There's laws in place, one in particular called the EMTALA, that basically says you can't turn away anybody regardless of their ability to pay. You have to at least stabilize them. Now, after you stabilize them, you don't necessarily have to do anything further than that, but you have to at least stabilize them. So if a homeless person stumbles in off the
What happens
street,
if they die?
No,
after
cause
that?
I know one night, we was in Cape Valley. I was with my cousin, she was going to the scene, and this one guy came in, he had a gunshot wound. They stabilized him, but they didn't actually move.
right,
So all of us died.
right, yeah.
My dad had.
So he probably didn't have insurance.
He didn't, my dad was waiting on
That's cool.
disability, so you have a 2-year wait period for insurance. And he had conjunctive heart disease. And they would only treat the symptoms, they wouldn't do anything for it
Right.
until that insurance kicked in.
Yeah.
Now, what's the, like, people that don't have insurance, I know, it's like a charity fund or something?
Charity care.
I think so.
Hospitals, most hospitals provide some level of charity care. There will be some cases that they just kind of take and they write it off.
Yeah.
How much charity care they provide depends on the hospital. That's going to vary from hospital to hospital. Again, it's going to depend on their status, if they're profit or not-profit hospital. Obviously, a non-profit hospital is probably going to provide more charity care than one that's a profit hospital.
Now, how does that work? Like, you have to be approved for it?
I think the policy is different depending on each hospital. Typically, most will have a budget. They'll estimate we're going to spend $500,000 on charity care this year. So if they reach that $500,000, they may decide not to do anymore. But some may not do it like that. Some may do it on a case-by-case basis. I'm sure, but they have to have some type of criteria, like you said, as to if they're going to do it or not.
But don't
So
they
that's
write,
fair.
don't they write off all unpaid medical bills anyway? You know, if they're not paid, I know they send them to a collection agency, but doesn't the hospital write them off and get credit for that tax credits?
Some. Again, it depends on their status.
Okay.
If some are like 501c3 or nonprofit,
Mhm.
it's going to be different than those that are for profit.
I was just wondering, just like people with credit cards that don't pay, you know, they write them off and they're gonna call these people.
Yeah.
But the company's already wrote them off and got tax breaks, so.
Not always necessarily a tax break though.
Yeah, I mean, well, you know, it's already been a write-off or a charge-off or whatever.
Plus, you have to remember that the tax rate has a ceiling.
Uh-huh.
So what they write off, they may not get a tax break for that whole amount.
Oh, okay.
Yeah. And again, all that kind of depends on their status. Do you have a question?
No, I don't have, I wanted to say on that care, the charity care thing she was talking about, at Cape Fear, the registrar's office, they'll give you like a list and of the people that will do it, and you just fill out an application for it.
Yeah.
That's how we do it at Cape Fear. Sometimes when the registrar comes in to get your information, like if you go to the emergency room, they'll automatically give you the paper if you don't have insurance.
Yeah. Each hospital is kind of different as to how
Which one?
how their policy is. Some hospitals will give you a piece of paper, tell you where else you can go if they can't provide the charity care to you. So, kind of just depends.
Now, say like if a person in a real critical condition and they don't have insurance, will they like, they need to send them CHAMPVA, will they send them?
So I say it again?
Like if they're in real critical condition
Uh-huh.
and they don't have insurance,
Uh-huh.
will they like, if they needed to, will they send them to CHAMPVA?
They
Still
will
be seen.
stabilize them.
And they're here in Fayetteville and they're in critical condition. You tell me the answer to that. Think about the cost that it's going to take for them to send them there.
That's what I'm saying, will they still send them, or they just stabilize?
They're going to stabilize them properly.
And
That's
not
it.
do nothing
Because the
else?
cost to airlift them or ambulance, that's on the hospital.
So
What if they die?
Yeah, that's what I'm.
They can say they stabilized them. They did what they were
That's all
supposed to
they
do.
have to do.
That's the law. Like the basic minimum of the law is to stabilize them. Now, if they don't do anything, they don't even stabilize them, yeah. Then we're talking legal issues.
So if they stabilize them, they can refer them to Chapel Hill or some.
They could, yep. But they don't have to do anything further.
This one is crazy.
Any other questions? Good questions, all good questions. That's all I have for today. We're done with our health insurance discussion. So, if you don't have any other questions,
Or at least, you know,
then we're done. What'd you say?
So maybe we can make it early for our next class with this poor.
Yeah, there you go.
I have a question.